Hello everyone, welcome. In today's video, we shall be looking at iron deficiency anemia in children. Grab your piece of paper and pen and let's go. First of all, we need to know that iron deficiency anemia contains two words: iron deficiency, then anemia. We know very well deficiency means lack, then anemia means reduced red blood carrying capacity. Now, in iron deficiency anemia, we shall say that this is a microcytic hypochromic anemia resulting from insufficient iron for hemoglobin synthesis. Now, this will lead to the reduction in oxygen carrying capacity, but this one varies from one age to age, and also the poor people are highly affected due to reduced nutrition. So, I developed this table to show you how anemia comes in, and this anemia, we know very well, is resulting from the reduced iron levels in blood. So, from 6 to 59 months, someone to have anemia or the baby to have anemia, the HB level should be less than 11. Then from 5 to 11 years, the HB level should be less than 11.5. Then from 12 to 14 years, the HB level should be less than 12. Now, at this point, we shall say the baby or the child has anemia. Now, let's look at the epidemiology of iron deficiency anemia. At the age of 6 months to 3 years, we see very well that there is high peak and increased levels of iron deficiency anemia among the children in this age bracket. And the high risk group include the preterm, whereby these ones we know very well the iron stores have not developed properly and iron has not been stored properly. Then those ones who are probably those ones who don't exceed 6 months and they don't have supplements. Probably there is rapid growth phase in this very age bracket, poor socioeconomic status, and chronic infections. Now, these chronic infections tend to reduce the levels of iron in the body. For example, malaria, ailments, and so on. Now, we'll look at the global burden, whereby iron deficiency anemia contributes 50% of the anemia in all patients globally, and it's the highest burden in Africa. Then in East Africa, it is 15 to 30%. Then in Uganda, it is 16 to 41%, and it's a severe public health issue. So, what could be the causes of iron deficiency anemia? First of all, iron deficiency anemia, we know very well, we have defined it as reduced iron levels in the body. This can happen in several ways. For example, inadequate intake. Now, inadequate intake, probably these children who are delayed to take complementary feeding. For example, those who have been breastfeeding for some good time without complementary feeding. Now, we know very well breast milk does not contain iron. And once the baby breastfeeds extremely past the supplementary period, it means that they will be lacking iron in their nutritional capacity. Diet in low bioavailable iron. For example, patients or people who use plant-based diet, let me say the vegetarians, we know very well there are very few crops that contain iron within them. Then also we have excessive milk intake. Milk reduces the iron absorption and also causes occult bleeding. So once these come in, it means that the body will face problems with storing or needing iron to make the red blood cells. Then another point is increased requirements for iron. So we know very well at this age there is rapid growth, the age of infancy, adolescence, and also prematurity. In this phase, there is rapid and excessive increased requirement of iron within these people. So at this point, it means that the reduced levels of iron will be compromised. Another point is blood loss. Now, for blood loss happens in patients who have hookworm infestations, who have GI bleeding, patients who have malaria, patients who are menstruating, for example, the girls who are in adolescent period. So in this point, we the patient is going to be losing, or the child is going to be losing excessive iron through blood loss. Malabsorption. Now, for malabsorption in diseases like celiac disease, these conditions will compromise the absorption of iron into the body. So let's look at the pathophysiology. Let's look at how iron deficiency happens. We will begin with iron metabolism basics, whereby we need transporters, we need stores, we need everything such that the body can store or the body can absorb the iron. Now, iron, first of all, is absorbed in the duodenum in the form of ferrous iron. Then it is transported via transferrin. Now, transferrin is the transporter, like the person who is carrying the iron from one point to another. Then we have ferritin. Ferritin is going to be like our store. Now, ferritin or hemosiderin, these are the store point where we store our iron, if at all we have been transporting it from the duodenum and so on. Now, for iron deficiency to happen, it means that there will be iron depletion. First of all, iron in the body will have to reduce. This means that the ferritin, which is our store, the stores will become empty and the stores will release the iron they have. Therefore, normal hemoglobin will be formed. Now, persistently not taking in iron means that the body will resort to other mechanisms whereby we shall go to another stage where there is iron deficient erythropoiesis. Now, at this point, the serum iron levels will have to reduce and the total iron binding capacity will increase. Now, this happens when there is reduced amount of free iron circulating in blood, and this will cause fall in the HB levels. Now, once the HB levels start to fall, it means that anemia is setting in. And for iron deficiency anemia, which is like stage 3, HB levels will also reduce. Then the red blood cells will become small and shrink, a term called microcytic hypochromic anemia. Now, what happens? What are some of the effects? First of all, hemoglobin synthesis will have to reduce. Like the consequences of reducing the levels of iron, hemoglobin synthesis will reduce, the red blood cell size will reduce, the color will reduce, and we shall have tissue hypoxia. Now, the reduction in the size of red blood cells, this is called microcytosis. Then reduction of color is hypochromia. So that's when we have the microcytic hypochromic appearance. So what are some of the clinical features? First of all, we have the general symptoms and symptoms due to anemia. Now, the general symptoms will include fatigue, irritability, we shall have poor feeding, and poor school performance. Now, how does this happen? For example, we know very well in the synthesis of red blood cells, we need iron. Now, it's not only the synthesis of red blood cells where we need iron. There are also some other biochemical reactions where we need iron. For example, in the electron transport system where we are forming ATP. In a patient who has iron deficiency, it means that there is insufficient oxygen transportation to the tissues. This means that the tissues will resort to anaerobic respiration, causing reduced levels of ATP. This means that a patient will become fatigued, will become irritable. The signs of anemia will include pallor. Probably this one can be seen in the palm and the conjunctiva. Then we have tachycardia, we have flow murmurs. Now, how does pallor happen? Of course, pallor happens when there is reduced perfusion, reduced blood flow to the capillaries. Now, this one will make the skin to look pale. Tachycardia happens when there is compensation, because there is reduced blood levels. It means that the heart will increase on the rate such that a lot of blood, actually the small amount of blood which is available, is sufficiently taken to the rest of the body parts. So we'll look at iron deficiency specific features. Now these ones happen probably showing that exactly iron is the one which is missing in the body. Things like pica. Pica means a person is craving for soil. Now, this one is always seen in mainly people see in pregnant mothers, but also in this case, you will see that your child will be craving for soil. Trouble in concentrating, we have seen that one. Eating less, that is loss of appetite. Sleep disturbances, we have looked at that. Now, we have angular stomatitis. Angular stomatitis, these are like wounds around the mouth. Glossitis, probably inflammation of the tongue. Brittle hair, chelonicia, the spoon-shaped nails. Now, these ones happen due to the reduced iron levels. We know very well that for keratin, we know that hair and the nails, they contain keratin. Now, keratin, for the body to make keratin, they need iron. Now, some enzymes which make keratin need iron. Now, in the body where there is reduced levels of iron, this means that even the keratin that will be made will be soft, causing the hair to be brittle and easily falling off, and also causing these nails to bend due to the external forces. Now, that happens due to the reduced levels of what? Iron. Now, we have severe cases. Now, in severe cases, we have heart failure, especially in infants. We have developmental delays. We have increased infection susceptibility. This is because immune system is, of course, compromised. So how do we approach when we're examining a patient or a child whom we are suspecting to be having iron deficiency anemia? First of all, we have seen the general signs, pallor, growth parameters, we have seen them. Vitals, of course, we have to check for the vitals, things like SpO2, heart rate, respiratory rate. We'll see that these ones are going to be increased. For example, the patient will have tachycardia. I explained this. Now, if you check on the skin, you shall have chelonicia. Chelonicia is this point where the nails are spoon-shaped. Now, these ones I explained to you, and I told you that these ones come as a result of external forces onto the brittle and soft keratin within the nails. Then we shall have in the mouth. Once you look at the mouth, we shall have glossitis, things like this. Then we shall have wounds at the angle of the mouth, called angular cellulitis or stomatitis. Then for the CVS, we'll see that we shall have phleomamas and increased heart rate, as we have seen in the vitals. Then in the abdomen, we shall have hepatosplenomegaly. This one is very diagnostic in severe cases, whereby the spleen and liver will do what? Will increase in size. So what are some of the investigations that we can carry out to assess iron deficiency anemia? First of all, we have full blood count. Now, for the full blood count, we shall say that the HB levels will be what? Will be reduced, meaning that it is going to be less than the normal, which is 11.5, 11, and also 12 grams per deciliter. Now, we shall see that MCV will be reduced. Now, this is going to be less than 80, because we know very well that the normal MCV is 80 to 110. Now, these values will depend on the given lab, but for iron deficiency anemia, MCV will be reduced, giving us the microcytic appearance. Then MCH will also be reduced, meaning that this is hypochromia. We shall have hypochromia. Then we shall have RDW increasing, something called anisocytosis. Now, once we do a blood film, a peripheral blood film, we shall see microcytic hypochromic RBCs. This one is evidenced at this point here. This is our what? This is our normal red blood cell. Now, if this is our normal, this is the smallest. Now, this one happens, and this is called microcytic cell. Now, this one happens in iron deficiency, anemia, and thalassemia. Now, we shall have also our pencil cells. Now, pencil cells, of course, this is how they may look like on your peripheral blood film. Now, we shall also see anisopoikilocytosis. Now, anisopoikilocytosis means that different and several red blood cell shape. These ones also be seen in iron deficiency anemia. Then we can also proceed and do our iron studies. Now, for iron studies, we shall have reduced serum ferritin. Now, this one is the most sensitive because we have seen very well that in a patient where the ferritin levels have been reduced, these patients are at the risk of having iron deficiency anemia. Now, ferritin, we say this is the storage form of what? Of iron. Now, we also see that serum iron will reduce. Now, this means that the free iron in serum will also reduce because there is inadequate iron in the body. Now, this means that there will be free total iron binding proteins. Now, this one will increase, probably the total iron binding capacity will increase due to inadequate or due to the reduced free iron circulating in the body. Now, transferritin circulation, of course, this one will reduce because there will be no free iron to transport and so on. Then, some of the additional tests that we can do, stool analysis. Now, for the stool analysis, will help us to see where there are hookworm infestations. Now, these ones tend to irritate the intestinal mucosa, probably the duodenum, hence causing the malabsorption and other forms. Now, we can also test for malaria because we know very well how malaria can affect our red blood cells, and also we do our occult blood. If at all it's there in stool, we can say there is some GI bleeding, hence causing reduction in the iron in the body. Our differential diagnosis, we can have thalassemias, we can have normal or high blood count, we can have anemia of chronic disease, we can have increased ferritin, reduced ferritin, lead poisoning, basophilic stippling, sideroblastic anemia, ring sideroblast. Now, very many of these topics will be discussed in my future videos, and stay tuned and always search about them because a lot will be said on these complications or differential diagnosis. Now, how do we manage this condition? We manage this, we have our general principles like how we proceed or how we approach the patient whom we have diagnosed with what? Iron deficiency. First of all, we need to confirm our diagnosis. How do we confirm? We have done our investigations, we have done our proper history taking, we have done our proper examination, and we have found what we have found. Then we can confirm our diagnosis. Then, of course, we have to identify and treat the cause. Then we replace the iron stores and we monitor the responses. Now, administration of the patient is needed once the patient is like in severe conditions. Now, we expect that the reticulocyte count will increase within 3 to 5 days, and also the levels of HB will increase from 1 to 2 grams per deciliter in 2 to 3 weeks. Now, we can do our iron therapy, whereby our oral iron is our first line, where I shall give ferrous sulfate. That's according to Uganda clinical guideline. For example, a child will get 3 to 6 milligrams per kilogram per day elemental iron orally. Now, this one can be given BD or TDS depending on the person who is prescribing the drug. Now, this one you can give it for 6, sometimes 4 weeks, and you continue for at least for 4 or 3 months. Now, that period helps to replenish the iron stores. Now, we have parenteral iron. Now, parenteral iron is indicated in patients who have malabsorption, because if at all you have now done your investigations and you've seen that this patient has a problem with absorption, now here we shall do our parenteral iron. Now, a patient who has severe intolerance to iron, to oral iron, still we can also do parenteral iron. Then a patient who is not complying to iron, a patient who has chronic kidney disease, still we can prefer using parenteral iron. At a point where the patient has severe anemia, whereby the HB levels are less than 4 grams per deciliter or less than 6 grams per deciliter plus signs of heart failure, of course we have to go for blood transfusion, where we shall give 10 to 15 milligrams per kilogram of packed red blood cells, where we give over 3 to 4 hours. Now, we know very well that if at all we have known the cause, of course we have to manage the cause. Then we have to do deworming, where we shall give albendazole 400 milligrams. This one applies to children who are above 1 year of age. Then we treat malaria if it is present. Then we counsel the patient or the mother on how to manage anything about complications, and also nutritional counseling. Some of the complications may include developmental delays, recurrent infections, heart failure, because heart failure happens mainly due to severe anemia, because the heart will be overworked to meet the demands of the body. And in a patient who has anemia, of course the demands will not be met, and also this patient may face other complications like organ damage due to tissue hypoxia and reduced blood flow in distant parts of the body. We shall have growth retardation. Of course, this one we know very well how it happens. Growth retardation, the growth rate of the baby will be reduced due to inadequate energy. ATP, we know very well how ATP is formed, because now if ATP is reduced, it means that even the functions of other body cells to grow will be compromised. So how do we prevent iron deficiency anemia? First of all, we do supplements. So we give supplements in children whom we see that they are at high risk. We can do dietary advice, whereby we get foods that are rich in iron. For example, the liver, oysters, spinach, pumpkin seeds, a lot of them, cashew nuts, and very many. Then we can do deworming. Then we can also do food fortification. Thank you for watching. Please like, share, hit the notification bell, subscribe, and we will meet in our next video. May God bless you.